excited about that. I couldn't think of a better way to be kicking off this conference than with Dr. Tong. He and I have known each other for well over a decade. I'm not going to date us, so I won't say how many decades, but well over. And he and I both trained at Stanford together. He and I, for a brief moment, overlapped as members of the board of governors of the Stanford Medical Center. And so that was a wonderful time. We both enjoyed serving in that capacity. And, have kids at similar ages, both live in the Bay Area, both passionate about healthcare, really, and more than just beyond medicine, but healthcare as an entity overall. Ian, I'm going to let you dive a little bit into your own particulars as far as background and setting up the talk. But again, just a warm welcome. We're all very excited to have you here this morning. Thank you so much.
Yeah, and Jeff, thanks so much. Really appreciate that, and I love it. First name basis is good with me if that's how you guys are running it. So thank you so much. I'll call you Jeff. I was thinking like, oh, am I gonna have to refer to Jeff as Dr. Pollard? But I will if you want me to. But I'm fine with the first names. Thank you guys very much for inviting me to talk with your group. And I was listening to the end of Olivia's comments and in the Q&A, and I saw a couple of things that I was just thinking like, yeah, these are good points to hit. And so I'm gonna give my introduction, but maybe just kind of segueing from some of the comments and questions that were top of mind for some of you all. What I agree with Olivia that this is a really an important and highly skilled group of our overall healthcare ecosystem and our workforce, our clinical workforce. So you are all our professionals with a very unique skill set that works really well at the bedside. I think it works really well at the screen side as well, and with screen side manner in addition to your bedside manner. And that's a good example of a translation that I think that Olivia was talking about earlier. But then also I think maybe one of the goals that I'm hearing is to really advocate for moving into the executive pieces of creating a digital health ecosystem that improves access to care for our population, and then also honestly I think provides health equity and for our population. And so there are so many opportunities and things that I think a career in digital health can do. I think doctors, nurses, pharmacists have a very high level of skill and training that's often measured and metered with certification and accreditations. And I think those are important and have their place. I agree with Olivia there, but I think it's the ability to integrate that high level of educational discipline with being able to think on your feet and again integrate and translate sort of the book the book learning skills to actual practical bedside, screen side, or real life situational skills. That's what makes, I think, the healthcare professionals of being physicians and nurses and pharmacists and so on really just really unique if you ask me, because you can be and learn the skills similar to an MBA or someone who's in finance, but it's really difficult for them, I think, to actually gather the clinical pieces. It's just to get that exposure is a privilege that really is reserved for the health professions. And then probably more importantly, the ethos, that's underneath, that underlies the why for so many of us, the sense of purpose for why we do what we do. We are all oriented to help people. And so I can't think of a better group to be engaging this type of conference and thinking forward about how to translate these skills than a group like the nursing group, which I think some of the trusted, most trusted brands and professions in our field are pharmacists, nurses, and physicians. And it might be in that order, or it might be nurses, pharmacists, and physicians. I don't know, but either way, those groups are all at the top, and I think I think that's something to be proud of, and it's something that you've earned. So, I think the other thing that was coming up was just people wondering about how they fit in and can move forward. And I would say in a digital health future, and I would say don't give up the training that you had. So I would hold on and be proud of all the certifications that you've already completed, and I would agree with being a little stingy with your time when you think about what you want to add on, because you already have great skills, but I don't think there's anything wrong with with utilizing those skills and promoting them as something that you have achieved, and then but then doing that little bit of extra work to talk about how you can translate it into a new job and a new role is really important. And I think some ways to give yourself an opportunity to do that is like beginning to think differently. Think differently and talking to other people who think differently. So that might mean going to an incubator. Stanford has one. There's a number of them, around the country now in academic medical centers where health systems are actually helping to seed or fund new companies, and you don't have to necessarily go there to be you can be a founder, but you can also network with those groups of people that are thinking differently about disrupting healthcare and changing healthcare for the better, reinventing some part of care delivery, or working on a very point solution for a very unique niche problem. But all of those opportunities are out there for you to be able to engage. And so I would just say, maybe stepping a little bit outside of who you might normally talk to in a given week or month, and asking questions about what they're doing, what they are thinking about for the future of healthcare can really give you an interesting and new perspective. I never myself sought a secondary degree after getting my MD. I had classmates that did MD PhDs, and they've had very rewarding careers, at the intersection of translational science. I have a number of colleagues and friends who went on to do an MD MBA. I think that can be really valuable. I just, the way that I came to where I am now in my physician executive role is really just taking my skill set from the past, right? I didn't throw it out. I didn't, I've always had MD. Once I earned that, I've always had that behind my name. I think RN should be the same. I think it's something to be proud of. But I just took that and I really entered into a pivot position. And so I ended up in a pivot position when I took a medical director role in a startup company. And so I'll talk a little bit about making that transition. And I will go into some slides, but I just wanted to be on the screen with you all a little bit because, I've been locked up, in COVID for 5 years. So it's nice to be able to, try to create a little bit of a connection and with you all here before I just start running through some slides at you. But I do think the pivot position is an important one because it allows you to take your past skill set and then translate that to what your new skill set is going to be. And often that pivot position implies that you're in a leadership role, but also as a professional. And so for me as a medical director, I was actually overseeing quality for the clinical development. I was recruiting other clinicians. So I was using a lot of, the language and skills and experiences that I had as a clinician and as a physician leader and in my new role within the startup company. And then as I was there, I was learning all the time. And then eventually I was promoted into the chief medical officer role of that company. And I can say, we can say some things about that if you all have questions about, but I've seen chief nursing officer roles. So I think a lot of what I'll probably say when I'm talking about my experience as a physician should and probably does translate pretty well, to a nursing professional, I think. So one thing I'll say is, that I don't even know if Jeff knows this, but I do have a strong affection for nursing, for the nursing professions. My grandmother, so I was born in Oakland in Northern California, and my grandmother was a nurse, and she was early on in Kaiser. She moved to California. She did a nursing program after being educated and growing up in Texas. Then she went to Kansas City, and there was a nursing program there. There weren't many around the country, but there were a few nursing programs that were actually educating Black nurses to be able to achieve, to gather the skills and obtain the skills of nursing and serve the Black community. And this was after the Flexner report, if you all have ever heard of that, but there used to be a lot more places where people of color, especially Black doctors and Black nurses, could train in specific schools that were aimed at training them and were run by Black faculty and professors, or a combination or mixed faculty. But many of those schools were shut down after the Flexner report, probably disproportionately. That Flexner report impacted the Black community more than other mainstream medical schools and nursing training schools. And so my grandmother was lucky enough to get into one of those programs. She then moved from Kansas City, where she was trained. Instead of going back to Texas, she actually moved to California in the 1930s, and that was to the Bay Area in Oakland. She worked for the Oakland Kaiser, which, as you all know, was a very early sort of pay-vider type of system that was serving people who were coming and working in the shipyards of Kaiser. And so that's, Kaiser sort of grew out of the need to have healthcare for the workers who were actually building the ships. And this was at the time of World War II. And so that's how my family ended up getting to California. And so anyway, a lot of affection for that. And my grandmother ended up getting, so Kaiser was growing. And so their next hospital that they built was in San Francisco. And she was offered a position there. And just a funny story was that her supervisor, was filling out the form to submit for her to be, a nursing supervisor over in the new San Francisco Kaiser that was being built. And so she said, "Hey, Andy," that was her last name was Andrew. So she said, "Hey, Andy, are you Portuguese or Italian?" And and they knew each other well. My grandmother said, "I'm not either of those." And so she said, "Oh, I know. I was just kidding." She's like, "But that's the only options we can put on the form." So she said, "You're Portuguese." And so my grandmother got that opportunity because her supervisor had the courage, but also the sense of humor, but also social justice to say, well, we're just going to use the form and we're going to fill in the slot. but I think you can do this role. But also, it's true that my grandmother's complexion actually gave her that opportunity where other people may not have been able to have that opportunity. But I would say that she made the most of it and helped raise me. With my parents were both professionals. My grandmother lived with us growing up, and so anyway, just that's just a little bit about my early background. But as I said, I'm local to Northern California, born in Oakland. I grew up in Fresno, California, then went to UC Berkeley for my undergraduate, and um, and I was an intercollegiate athlete. So had the opportunity to play rugby for UC Berkeley, which was a great experience. I think I learned a ton of things there about competitive spirit, being a good teammate, and I think it also sort of planted the seed probably about being engaged in constant improvement, which by the time I ended up in a health profession career, I think translated well to lifelong learning. When you're an athlete, you're always surrounded by other people who are good at what they do, and they're sort of a friendly level of competition. And you want to be you want to be just as good as them. You want to contribute to the team, and then sometimes you want to be even better than them if you can be. So you want to be the best that you can be, and so that certainly has been a theme throughout my early career and carried over into being a professional. And then eventually I think I just developed the desire to continue to learn, but also find purpose in my work. And I think if you ask me like what are the driving principles, and maybe a theme for this talk, are just thinking about being able to use your professional career to find a sense of purpose in your work. I always like when the speakers kind of say like, well, if you only pull away a few things from this talk, this is it, so you can remember these. And I'd say, having a sense of purpose for what you do, it will always guide you well if you can maintain a focus on why you're doing what you're doing and who are you impacting and helping. So I think that sense of purpose is super important. I think also a theme that came up that Olivia mentioned that I think is true as well for myself is, having some level of autonomy. So I think it's very important, as a trained professional to be able to put yourself in a position where you get to use your training and where you get to use your decision-making ability, and the breadth of knowledge and the depth of knowledge that you have to be able to exercise judgment as a professional. And so we talked a lot about AI, and that's what's I think that's one of those very clear things that I think AI lacks. It can borrow from other people's judgment. It can borrow from millions and billions of examples of decision making that other people have already made, and come up with the most likely statistically probable decision that those that mass of population would make in a given scenario or situation. But you can kind of see where there's also big gaps there if you don't actually have the ability to question when here's the rules that exist in a health system, or maybe the protocol that exists in a for a nursing floor or for a patient care unit. But there are always scenarios, as you all know. Maybe it's 1% of the time, maybe it's all the way up to 10% of the time. But that's when you need a professional who can actually exercise autonomy and make a decision and actually override the protocol. And I think that's a super important theme. And so I actually don't love calling things protocols. I like to call them guidelines. There's a good legal reason for that, but also I think there's a good mindset reason for that as well, which helps us maintain our professional decision-making ability and our autonomy. And then the final thing I would say, theme, so purpose, autonomy, and then mastery is the third. And I didn't invent this. This was that framework. It's a framework that exists in the medical literature. Usually, it existed as purpose, autonomy, and impact. But more more popularized by authors like Daniel Pink and Dan Ariely, who are who are behavioral economists and thought leaders. And they really saw that developing mastery in an area is also something that's just extremely important to a professional. So we talked about that a little bit already. But so yeah, let me go ahead and say I'll jump into the slides here. So let me share my screen if I can remember how to do that. I think I go to the sharing part, and I'll share that to you all. Let's see, video. Oh, there we go. Here we go. Share. Duh. All right. Okay. Do you all see my? I can put it in. Let me put it in slideshow, and hopefully you see that. So just let me know if you don't, but you should see a slide that says beginnings. So I've already given you some of this, but I just, little visual aids never hurt. So along my path, I ended up leaving the Bay Area to go to medical school at the University of Chicago. And then I made my way back to the Bay Area for training at Stanford. I got to be the chief resident there in internal medicine, along with a few other colleagues. And I ended up joining faculty and staying on there for a number of years, lived on the peninsula, and just built a great network of friends and colleagues, but also always, also just kind of growing up there as a professional. It's hard not to see what's happening around you in the corporate world and in the startup world on Sand Hill Road and the venture capital world. And so I had an exposure and appreciation that there was a bigger set of, a bigger world and a bigger set of opportunities going on outside of where I was. But I was honestly very satisfied with being a good doctor and being trying to be a good educator and trying to do the best, and try to do the best that I could do for my patients. And so one way and always along the way, finding problems that I thought I could potentially contribute, a solution for or being able to solve. And so one of those that I noticed was with my first job, which I think was a major inflection point for me, was getting an offer to join the VA Palo Alto healthcare system as the medical director of homeless veterans outreach. And so they did not have a program actually before, but I was offered this opportunity to build a program. And when I look back at it, that was really, maybe that was my first startup actually. It may have been because it was actually an opportunity to start something new. It was really a clean slate of paper. The program didn't already exist. And so we had to bring together a number of resources to make this program work and function. And it was in that program and that opportunity is where I discovered that the VA had this amazing infrastructure within it that had telemedicine services. And I started writing grants for rural health to try to improve access to care for rural veterans. And it was that experience that actually introduced me to telemedicine. And that entire opportunity to build that program and to build it within the infrastructure and framework of the VA gave me a lot of confidence around how the future of virtual care could look. And just to make fun of myself, when this was all going on, Olivia was pretty close. I think she said like 2012 when maybe this was all starting. So I'll answer that question. This was actually for me at least, this started, and telemedicine journey started around 2007 and 2008, and that was the first year that the first iPhone came out. So to make fun of myself, I actually had a BlackBerry then, if you all remember those, and I loved that BlackBerry, and I just thought it was the best piece of technology. And I honestly saw the first iPhone come out, and I said, well, who would want that? I don't think I'll ever need one of those because I've got this BlackBerry. And so, but eventually when they started putting the cameras on the phones for the iPhone, and I was working with this telemedicine equipment within the VA, I could kind of see that one day these things may come together. And so then in 2013, I was offered an opportunity to join Doctor on Demand as their medical director. And so that was really, that's what I would call the pivot position that I was in when I got that opportunity to work with them and build out that practice. And so I'm going to say a little bit more and talk about that experience with Doctor on Demand. Currently, I'm the chief clinical officer at Foresite Labs. And I'll say a little bit about Foresite in a second. So where I'm working at Foresite Labs, we are a virtual creation platform or a venture studio. And I'm sorry, I said virtual, but venture studio. So we do the underlying science, and do the foundational discovery that informs the opportunity to build companies that practice precision medicine or develop drugs that are really precision medicine treatments for certain conditions. And so we've launched over 5 companies now at Foresite, and those companies have been successful in bringing on external funding from other investors. And one of the companies here, Loomis, just went public last year. That was announced. And Zera, some of you may have heard about, which is a new company that's an AI/ML drug discovery platform that just had a $900 million raise last year. So that also made the news. And the CEO of that company is Mark Tessier-Levine from Stanford, and the company was co-founded by David Baker, who's just won the Nobel Prize, I think, in chemistry. I think it was for 3-dimensional protein folding. So it's so really I've always been curious about being on the cutting edge, and I think this started in a way at the VA, which may not be the place people expect you to find yourself on the cutting edge, but the VA was always very cutting edge on telemedicine. They were ahead, and I think that theme has continued forward into my current job. But I'll share a little bit more about that journey. One thing I will say about telemedicine, to Olivia's question of when did this all begin, it started way before 2007. They used to have some, the early days of telemedicine was called POTS, which is plain old telephone service. And that's still a really important backbone of our telemedicine system today for various applications of telemedicine. But there were people who envisioned the future, the life that we are living now and the discussion that we were having today about digital health. There were people who envisioned all of this, many years ago. So yeah, are we talking about disruption? Yes, we are. But I think the earlier conversation you all had was something that I had built into this talk, because I do think it's important, as I said already, to not throw out the old for the new. We have the nursing profession is built around a number of core values and principles, and so again, like I said, I would embrace those. Many of you are thinking about and exemplifying these in your work every day, and I will tell you that the most people that are outside of healthcare, they do not have something like this, like the 6 C's of nursing, where there's care, compassion, competence, communication, courage, and commitment. These could sound like just words, and they can sound like buzzwords or things that are just nice to have or fit well in a framework. But these frameworks are actually really important. Educational frameworks, learning frameworks give us all a structure to build around and become those autonomous decision-making professionals that I talked about earlier. And so I would just, this was more of a reminder not to throw those out, and I would encourage you all, if these are your, some of your core values, I think it's great to think about them and think about examples of how you exemplify these, and especially a good primer for when you're going out to think about jobs and interviewing jobs. And along that theme of of having, strict training and procedure and protocol. I would say that one of the professions that I would use as, just a really excellent example of where the treatment modalities and treatment, offerings have expanded and moved forward and really started to make our integration with technology and other tools and mechanical tools and automated tools, really bringing that forward is really this area of robotic surgery. So this was not always the standard of care, but now, it's seen as as a really important way for patients to get even more precise procedure, get better outcomes. And so this was proven over many years that there's the ability to do this. But this was not, welcomed when it first showed up. When the opportunity came to begin to intervene and to cut on another human's body, to trust that ability to do that precisely and to put a human being's life in the hands of a device, that was definitely seen as something that was fairly radical. I remember a talk when I was at Stanford. There was a grand rounds talk by a surgeon. This was around 2005 or so. I think it was when I was a chief resident, and he gave this wonderful talk showing the data that showed how well robotic surgery had performed and how it had grown. Just as a slide that I have here, just becoming more and more common. And and people were so excited, and they gave him a loud applause, and he was congratulated, and they patted him on the back about all the great work and all the great accomplishments that they had made driving this robotic surgery forward. And he did this really interesting thing at the end. He ended the talk early. He got all the accolades, and then he said, "By the way, we have a little bit more time." And he said, "I just want to tell you all a little bit of the history." And he went back because he had given a similar talk about at the very beginning of his career when he was engaging robotic surgery. He had talked to that in that same room. He'd given a grand rounds, and he said that he was literally shouted out of the room and almost chased out of the room because of what he was saying. And so people were just so offended at the concept of doing this, but now this is very commonplace. And so it just was a good lesson for me to see where it's okay sometimes your colleagues it's okay if your colleagues question you. Sometimes they might even dismiss what you're doing, but if you believe in it and you have a good reason and a sense of purpose for why you're going to engage in that forward opportunity, you can make great things happen, and you may have to earn it, and it may be a long journey for that surgeon. It ended up being a 20-year journey. But it was great, and it was a great moment to see him enjoying the approval and the celebration from his colleagues that that he had proven this and had the evidence to back it up. So I just wanted to say I think those foundational learning experiences absolutely have they have their place, and we should leverage them as much as we can. So I want to turn now to the telemedicine experience, because this is where I guess I sort of begin to differentiate my career. For many of you, there's, first of all, I don't think that telemedicine or telehealth is great branding. It's pretty bad, but it's very descriptive, at least. And I think people nowadays, they know what it is when you talk about it. But I kind of like digital. I do like digital health a little more. But anyway, you can tell already, I don't get paid to make up marketing slogans and campaigns or productize. But telemedicine really was the idea of being able to deliver services across distance, and it got its beginning in rural health. Because we had large parts of our population, about a third of the population of the VA, and I think it's something similar to that. Maybe 25% to 35% of the U.S. population lives in rural areas. We know that, and so, but they don't always have great access to services, and especially healthcare services. And so telemedicine was, as it entered into the market, was again not widely embraced, but it was seen as a compromise for people living in these more remote areas and highly rural areas, and it was a valuable tool that could at least give them access to some care if they couldn't get care that was offered in the metropolitan areas. So just to give you some idea about the different modalities, so this is one of the ways that I think about this, and the VA had this framework. There's synchronous, real-time virtual interaction. There's remote patient monitoring modalities. There's really this asynchronous, or what we used to call store and forward. And I think that these still, if you don't have a framework for thinking about this, you can use this. I still think it applies. What would fill in the columns to the right, the provider to patient or provider to provider examples here. Those could change over time. They evolve. So, chat didn't used to be in there. The VA didn't used to have secure messaging. Now we do, and now they're changing secure messaging. So the different types of tools will evolve. But the idea is that some of these models have been really proven over time, and they're not necessarily tele anymore. I mean, they're actually just the way that we provide healthcare. And so teleradiology has been around for 20, it's been standard and the standard of care, and probably even best practice in many cases for teleradiology for years. This is basically how radiology is practiced. You can get the world's foremost expert in neuroimaging to be able to read a scan, from across, from halfway around the world if you wanted to do that. And so luckily in our, the way we train, we don't need to do that every day. But when it really matters, the idea here is that you can have access to very high quality service. And again, I mentioned before, it's also a health equity tool that allows someone in the most remote corner of of a rural area to be able to get again that world's foremost expert in an area to be able to engage with them and get that their clinical consultation. And so there's a number of tools here that I think we can use more, and we will probably use more going forward. So happy to answer any questions about that. And by the way, please feel free to put questions in the chat as I'm going if something comes up for you. So as I was making this transition to leave my educational role and leave the VA and start to utilize the new tools, what I really learned about and was impressed with was this concept of product. I didn't know what product was, but it's an area where I think it's an area I would encourage some of you to look at. It doesn't have a perfect definition, but I think it's a really great place where people who have a very diverse set of skills, especially professionals like nurses and others, who can actually enter into this area. And you're not necessarily operating as your profession when you go into product, but you actually but you do a lot of integration work and translational work. And I think the best product people stay super focused on the end user and actually make what has not been accessible before, they make it accessible to people. They make it an easier experience, they simplify it, but also they maintain high quality. And so I'm just showing you a few screens here. When we were building out Doctor on Demand, which was the startup that I went to, we were reinventing the intake for patients. How could we make that more efficient? And once we had them fill this form out, we don't have to have them fill it out every time they engage us. So we were able to begin auto-populating pieces of their medical record that they had already given us. And then we were just allowing to come into a very continuous flow. We made it very easy for them to see a clinician. And so they were face-to-face, very different from the interaction that they would have if they went into a doctor's office where the doctor or nurse is looking at a screen. But here you can imagine where they have this face-to-face interaction. And a number of insights about what we learned there, but just one counterintuitive thing that we saw was that clinicians and patients were able to do the work in about half the time. So a normal clinic visit might take 20 minutes in brick and mortar practice, and you might have a patient that complains that the doctor or nurse didn't spend enough time with them. But in the case of virtual care, we were spending about half the amount of time, so maybe more like 8 to 9 minutes with the face-to-face. But the patients never said that they felt that the time was not enough. That was never a complaint that we saw. So I thought that was very interesting. And again, I think it was because of the overall experience. And then we could give them lab orders, or we could order their order medications. And so we integrated a number of tools into the platform that actually made care more efficient. And we were able to address that. But it wasn't easy. I mean, as we were developing the tools and entering into markets before COVID, again, a lot of people met virtual care and digital health with a lot of skepticism. So in the regulations in the government, there was a originating site requirement where you could actually in order for the government to pay for your virtual care, you had to go into a clinical site. So you essentially had to go into a clinic that was called an originating site, and then you could connect with a doctor that was at a remote site. So in my mind, that didn't make any sense. That really it sort of negated the value and the health equity piece, because there's patients who have social determinant of health issues that don't make it easy for them to get into clinic. And so letting them be able to engage this from home or from their mobile device, wherever they are, was really a democratizing healthcare opportunity that I thought we were missing all the way up until COVID. And to be very direct about this legislation still requires an originating site. It doesn't right now because Congress continues to extend parts of the public health emergency and part of the deregulation of digital health and telemedicine that occurred during COVID. But if they don't do that, or I'll make up a wild, far-fetched scenario like our government becomes a little bit more dysfunctional and isn't able to pass a law that actually puts this into permanent law, we could lose the ability for people to be able to connect with their doctor and and for those clinicians, doctors, nurses, pharmacists, to be able to be reimbursed for those visits. So this is still up in the air and not done. And I do worry about that because it's because I would say Congress has had a lot of time to right this wrong and remove this originating site requirement, but they're only doing it temporarily. So that's not a good sign, because we really want them to do that for the long term. And then there were other logistical and operational challenges, excuse me, in developing out a 50-state virtual medical practice. And so that included licensure, building the workforce, supervision. And so these are all logistical challenges, I would say, that can be figured out. We did a number of these, but in the early days also, we had to be our own evangelists for the service. And I spent a lot of time in my early days at Dr. Roman going around and actually evangelizing the benefits and potential value of virtual care. And one of those visits took me to a rural state that I'd not ever been to before and haven't been to since, but the great state of Alabama. And I kind of walked in there thinking, well, boy, I did a little bit of homework, and I saw where, this was an area where there were, almost the entire state was a primary care shortage or area, and where they were trying to, develop scholarships and do what they could to build out clinical workforce in their state. So I thought they would be very welcoming, but actually that was not the case. And so our attorney and I walked into their state medical board to inform them of what we were doing, and they were very unfriendly and inhospitable to us in that meeting. So just to give you some idea, it ended up we ended up winning the end of the day, but they actually denied our request to operate there for a very short amount of time. But then they rescinded that. But it was, again, just to give you some picture of the early days of developing out this offering. But we were not dissuaded by states like Alabama. Texas was also very hostile towards telemedicine. But again, we persevered and we continued to move on because we felt that it was the right thing to do. And so as we moved through, we originally launched as a direct to consumer. That's what D2C means. So it was a direct to consumer company. Meaning we went out and anybody could find us online. They could engage. We launched through the Dr. Phil show. So Dr. Phil's son was one of our co-founders. So we did a number of what we called TV integrations where we demonstrated for people how to use the platform. As we developed the practice and began to grow across all 50 states, we incorporated things like NCQA accreditation. We got cybersecurity accreditations. We did things that would make us appear and look very similar to any other healthcare entity, but the only difference was we were providing our services virtually. And then what we saw was some interesting things start to happen. Patients were coming, they were finding us thanks to being able to do these television integrations. But then also different types of patients started showing up at different parts of the day. In the evenings, we would have people that were more lonely and they had more behavioral health issues. And so we launched a behavioral health practice to address that. And that's still one of the fastest growing practices within the Doctor on Demand today, which is now called Included Health. And so they're doing thousands and thousands of visits every day in behavioral health. And so probably one of the largest telebehavioral health providers in the country at this point. And then we continued to build in other things like labs. I showed you that earlier, where patients were able to go to a Quest or a LabCorp to get, and we would do integration with their insurance to be able to match them to that, so that we could, they would not be charged. So it was all a very seamless experience to, again, start to to build out the capabilities so that we could compare our programs and our clinical quality to a brick and mortar practice. And so we just kept marching along, working again with product, as I discussed earlier, to transform the traditional brick and mortar experience into one that could be seamless, could be mobile and remote, and take a fraction of the time and actually really be delivered at a fraction of the cost. And then all along with the goal of that this service could also start to level the playing field and access points for patients from all walks of life and all levels of the socioeconomic status. And so, but then as you all know, this really big disruptive things happened to all of us. I think it's changed, it's changed my life, it's changed yours, and probably explains why we're today here and, doing this conference the way that we're doing it. It's a very efficient way to bring people together, but it was very disruptive for a while. Excuse me, take one quick sip of water. But we really hit a crisis moment, and I probably get a tiny little bit of PTSD when I think about this. So my apologies to anyone else who has that, but we're going to work through that together. Don't worry. But it was a very difficult time when COVID landed on our shores, and it was here much earlier than we even realized and that people realized. But just the number of clinicians who began to feel overwhelmed and that they potentially needed to make a change or leave the workforce was just staggering. And so you all may remember this, where we were seeing tens of thousands of physicians closing up their practices, the exacerbation of the PCP shortage. Over half the counties of the country are essentially healthcare or primary care deserts. So a lot, just a really scary picture. We published a paper on this with the CDC, looking at sort of the uptick of virtual care visits, and it's interesting. There really was a very sharp increase early on in COVID, but that was, maybe this was a good thing. We had the capabilities and infrastructure nationwide, because that peak of virtual visits came down very quickly for what the 4 largest telemedicine companies saw. So that was a good lesson. It was, for me at least, because a lot of people thought, oh, that must, you guys were the people for the moment. You had the right tools, you had the right platform, all of which was true. But the reality was there was a great deal of infrastructure already present. It just wasn't being used. And so now what you've seen is a number of practices, health systems, they were able to jump in early on in COVID. And so they were able to lessen the early burden here as well. And so I think it ended up being a good thing. It wasn't necessarily a great thing for the business growth, although because we had this really sharp spike and then it started to come down very quickly. But I think the overall awareness and understanding that people have that they can get a very high quality of service now, and in some cases it may be even better than our old version of traditional care, that realization really started to set in. And so I think in the big picture, even though it was a rapid spike in volume and demand for our service, and then actually a pretty quick decline in terms of demand for that service, the reality is that like a certain part of the population has now been introduced to this type of care, and that's just going to increase and continue to grow now because of that awareness, but also because of the need. And you all and someone else probably in this over this weekend is probably going to talk about that and just the market forces that drive, and I think will continue to drive more utilization of virtual care. So as you know, so after COVID hit our shores, and we were dealing with a global pandemic, a lot of these, healthcare was very heavily deregulated, and digital health specifically was deregulated, just so that people could, so that we could, execute on Operation Warp Speed, which brought the vaccine to market faster than we had ever seen previously. The president was on the television talking about virtual care and telemedicine, and they moved as much regulation out of the way as they could to allow these models to really help address the healthcare needs of the country. And so that was the right, I think that was positive and the right thing to do at that time. But again, there's probably some work to do on the policy front that will make those changes more permanent. And then moving forward, these are just some of the examples of the ways you could utilize virtual care in these instances. And so, there were severe cases, critical cases, and the more mild cases, and we were able to utilize the technology to build a risk assessment tool early in COVID. And so, without reliving the 3 times a day meetings of that crisis, I would just say, we were lucky to have the digital health tools that we could build quickly and disseminate broadly. And so, if you ask me, I think we learned some really important lessons about how to leverage those tools in the middle of a crisis. And so, my only hope is that that the powers that be remember this, and we'll have these tools for when we have our next global pandemic or catastrophe, and hopefully that's a long way off. But again, you have to prepare for this. We know better now, and so and I think the most important thing is that that maybe you all can hear is that it's really going to be critically important that we have the workforce of professionals and individuals who can support these support these tools and inform these tools and make them better for when this happens the next time. So on that front, there are definitely opportunities and threats in this area. I'm very bullish on it. I mean, I've had the opportunity to spend 10 plus years now talking to, and as I said, evangelizing the capabilities of this type of platform. So there were a lot of naysayers before, but it's really, I can see the evolution now where it's evolved to where this is sort of just understood now that we're going to be utilizing these tools. And just one thing that I'll highlight for you all that I think there's more opportunities than threats now, for sure. So some of this is a little dated, but it is part of the history of virtual care and the virtual care professional. But the reason, if I had to pick a few reasons for why I think virtual care is definitely here to stay, and you can't put that genie back in the bottle, is just the convenience and the access that it provides for the American public to actually engage a professional across distance is a hugely democratizing opportunity. But also, maybe even more importantly, the reason why I think it'll work and continue to grow is because people told us, and we actually published this in the Mayo Clinic Proceedings, the patients told us when they gave us 5-star reviews, they could volunteer comments. We didn't require comments, but they volunteered comments, and their comments very often, I would say, would comment on the individual, the person who cared for them. They'd say, why can't this person be my clinician all the time? And so you could see that they were developing a relationship with the person on the other end of that video encounter. So, I think that we're approaching a time when, these opportunities are going to continue to evolve and spread. People are able to see telemedicine has moved from like episodic to really being able to develop virtual primary care platforms. And you will see that that's being talked about more. And there are more digital health companies that used to never talk about virtual primary care. Now they are offering that. And so I think there's a tremendous amount of opportunity for the healthcare professions to recreate what we've been doing in person and in brick and mortar for decades now. Being able to do that on these digital platforms is again going to be extremely powerful. So this is an interesting thing, and this is not intended to make a political statement, but when I was kind of thinking and looking through and doing some research for this, I found something that I wasn't expecting to find. And so when that happens, I always like to call it out, but it's an interesting thing that we saw within Doctor on Demand. We had a very diverse workforce, and so I'll say a little bit about that more in a couple of slides, and then I'll end my talk. But this was just interesting as I was looking across our healthcare workforce. There's a huge portion of our healthcare workforce and registered nurses who actually come from outside of this country, which I think is really, really important for us to acknowledge, especially given some of the rhetoric that may go on around the country. But these are individuals who are going to take care of patients. And when we have an aging population, there's going to be even more need than there is now for more individuals who can actually support us, support our parents, support our uncles and aunts and so on in their homes. And so whether these are individuals who are in nursing or just healthcare sector workers in general, you can see that our immigrant population makes up an extremely important part of our workforce. And here, and this was the one that was the most surprising, but in the, across nursing, psychiatric, and home health aid services, you can really start to see the demand for this starting to spike now. And again, I think this is partially due to the fact that we have an aging population. We're getting older, we're getting older faster, and we're living longer. And healthcare breakthroughs are going to continue to drive us in that direction. So just to end up the doctor on demand experience and why I've emphasized this being a democratizing platform. So we didn't necessarily build for like this wasn't an intention that we stated, but we wanted to be an equitable healthcare platform. So we did talk about diversity. We trained on cultural competency, but we attracted an extremely diverse workforce. 75% women, almost half the practice of our clinicians were Black, Indigenous, people of color. A huge percentage of them would identify as LGBTQ. So we had this extremely diverse workforce, and maybe in the Q&A we're able to get into the reasons for why. But I'll stop there and stop sharing. Thank you all very much.
Ian, thank you so much. That was an incredible presentation, and you took us into some really personal and moving areas of your life and your career and your trajectory, and I appreciate you going there. It really gives us a lot of context and adds a lot of weight to your words. And one question I had is, or maybe it's just kind of summarizing, it certainly sounds like one of the prevailing themes is grit and grind, just kind of grinding. You pick whatever word you want, grinding, grit,
Yeah.
persistence, in the face of people telling you that your idea is bad or that the rules just don't apply or they're not going to change. So I wanted to just kind of like, we have a bunch of really entrepreneurial nurses in the mix here, and there's 100+ that registered for this conference and will see your talk, and more that will watch the archive. And I'm wondering for them, in this moment of kind of hearing about all the, like, it takes 5 or 6 years to get a company off the ground and against all odds, and how do they stay motivated to make the transitions? Because the bedside feels safe sometimes, and it may be what we're all trying to get away from, but that grit and that determination is really a key factor, it sounds like. Would you agree? And how do they stay motivated?
Yeah, absolutely. I think there's no question that that there's a need for this, and I think all I have to do is look across different communities across our country that have extremely long wait times, wait times of months to see a behavioral health clinician. Look across our aging population and the fact that as we get older and more frail, we are less mobile, and so we're not going to be able to, those individuals, when you work in brick and mortar practice, you're used to them coming in to the office and there's a waiting room and so on. But what we never think about is all the people that can't even get into that waiting room, and so I think that the demand for the types of services that you all can provide. I mean, you have to know that there's an unending need for those services, and so that to me is very motivating. And then also, I think the equity opportunity of this platform also is really. I mean, it's one of those things that's like it's kind of built in. Like you don't have to do it deliberately; it will just happen because you are building a more accessible platform for people with with disabilities, but also people who geographically live in remote areas, people who may lack lack the ability to pay, people who don't have insurance. I mean, there's just so many ways that you can argue that this type of platform is going to level the playing field for folks. And so those are really big motivators for me, and I'm sure they motivate you all. But then also it's extremely just cool to be able to provide services across distance. And I didn't talk about this, but it was on one of the slides. But we actually did surveys of our working population. There's a survey called Great Places to Work, and we did this for multiple years in a row. And when we initiated the survey, my coworkers and leaders in the company at Dr. On Demand thought they were really worried about the clinicians because they thought because they were all remote, they were actually going to not feel connected to the company, and they weren't going to they weren't going to love their jobs, and they probably were going to bring down the average of the Great Place to Work survey. They actually increased the average. They actually scored higher in terms of engagement and job satisfaction than the other. And so remember, I'm saying this in the healthcare profession, right? Like the doctors, the nurses, rated their experiences higher than the corporate employees of that company. So anyway, so that's just so I would just say there's a reward for you also potentially, if you can tough out the grit part and you can feel driven and inspired by the mission part, then then there may be job satisfaction and unexpected rewards on that side, of just, I mean, for me also intellectual stimulation, that to do something new and to deliver great service on a technology platform that's fairly new, and we weren't able to do before is pretty groundbreaking, pretty exciting.
There was a question in the chat. We're getting some thank yous too in the Q&A, so lots of folks appreciating your words. One question that got a little bit of clarification on was from Amber, who's a nurse in Michigan, which is not a compact state, and she's not
Yeah.
allowed, for example, to teach in a college remotely outside of Michigan. And her thought was, or her question really is that something that does that kind of limitation affect virtual care? Like those kinds of
You
thought
know,
process and rules or regulations that are in place.
that's something that exists. So I mean, first of all, so there is no compact equivalent state thing for for physicians. We don't have that. We have to get multi-state licensed. There is a shared application process, but so the nursing compact I would say is sort of ahead of the game there. I didn't realize Michigan wasn't one of the states that's in that because I mean there's a number that's over the majority of states I think are now in the nursing compact, which is really positive. So hopefully there's lobbying or work that can be done, but I think it's a good thing to ask the question why and understand why, because why is it Michigan not doing that? What I learned, and I'll be brief on this, is you can provide services across, you I should be careful with this, but you can provide services across state lines. It's actually usually more permissible to provide services professional to professional than professional to patient. So I'll just leave it at that without giving, I can't give legal advice, but maybe that's one that we could follow up on because there's usually having a conversation with, usually I wouldn't advise this, but having a conversation with the nursing board to get clarification on and understand the intention might be important because usually they're usually trying to block something that's nefarious, not block people from actually offering services that are needed. So.
Ian,
Yeah,
there's a very interesting question. Oh,
really quick,
sorry.
yeah.
Yeah.
Quick follow-up. Yeah, the policy and participating in, even your local governments, I think is important. We had a question during my talk about like, well, how do we kind of start this, future of nursing and being part of those conversations and just even aware of the local regulations and state regulations is a critical piece. There probably will need to be lobbying and different, discussions happening to create, these the worlds, when it comes to insurance or whatever. So I think that is really critical. And then I had a question for you. One remote role, and there are several nurse practitioners here, is telemedicine that NPs provide. But it seems like the companies want multiple licenses, which makes sense economically. But it is really cost prohibitive to get licensed in all of these states. Like they want 8, 9, 10 state licenses. I haven't heard of a joint application, for nurse practitioners. Are you aware of it?
Yeah, that's what nurse practitioners are kind of they're not in the, I don't know if that's because there's a different lobby, but they're, but there is for physicians, and I think there is the nursing compact, right? But not
Right.
for nurse practitioners. So unfortunately, they're sort of sort of left out of that process, which I don't understand why. But one thing I would just say is, the companies that I have worked for in this area are willing to fund some of your licensure if you're willing to give them time.
Mhm.
Like if you will contract with them to be with them and so that they can recoup the ROI on those licenses, I think that is something that I would just advise negotiating for at least for some of them. Once you have them, maintaining them, it is still costly, and so that's sort of a investment that you have to kind of manage if you're going to go from place to place. But if you have an employer, I mean, I would always just include that. And I think that the bargaining power of nurse practitioners probably is going to continue to go up because the disparity of supply versus demand of primary care roles is only going to grow.
Mm-hmm. Great, thank you.
Ian, interesting question just popped up. And I know we're going to keep you over a little bit here. I appreciate that if that's okay with you. And we'll start our 11 o'clock session with Olivia in just a few minutes. Also wanted to invite you. I know you're super busy and it might not work out, but we have a networking session at the end of the day. You're welcome to come back. We're not going to hold you to that. If you're available, I have no idea. I'm putting you on the spot, but you don't need to answer.
I'm actually going to a 50th birthday party tonight. That's a surprise, so I can't tell you. So you didn't hear it here, but that's where I'll be.
Got you. Sounds good. The question I'm going to kind of paraphrase, but it's getting at product market fit in a way. It's also getting at specifically asking about older populations with virtual care who may have cultural leanings towards wanting a traditional format. I'd love to hear your DoD kind of like version of like how elderly patients trended in adoption and how you had to kind of product market fit your offering to them.
Great question.
And then it kind of caps by saying like how specifically as nurses can this workforce help with adoption?
Fantastic. Okay. So the first part of that, absolutely. So, when the deregulation happened during COVID, so first of all, I have to acknowledge the barrier. What I said about that originating site requirement, most seniors are on Medicare, right? And so therefore the government's paying their medical bill, whether they're in a medical care advantage plan or not. But if you're on straight Medicare, Part B, like again, you had to go into a clinic to get the virtual care. So if you're going to do that anyway, you might as well, like, of course you want to be seen in person. So any survey that says, well, patients prefer to be seen in person is a bit biased, right? But absolutely, when they removed that originating site requirement, we saw an uptick of seniors. My oldest patient was 80 something, like 84, I think, who found us, saw it on Dr. Phil, signed up her, created her own account. And so the technology barrier is real, but once someone is brought on, and so I would say for the nursing profession, I think it's a great opportunity to actually even just getting people engaged on the service and offering that service would be of helping people set up a digital health account with a virtual care clinic of some sort is that's the VA employs people to do that for My Healthy Vet, and I would say and it's a big job. As I think it was seen as very successful in the early going in terms of adoption. I don't know about now. I mean, maybe it's not needed now because now people have other ways that they can connect, and just do video visits and stuff like that. They don't need My Healthy Vet as much anymore. But I think there are roles to provide the onboarding and engagement of individuals for that. If you ask me what I think the most rewarding way would be, I'd love to see more nurse and by the way, included health is I think more nurse practitioner now than MD on that practice. So the bulk of video visits there are being handled by those professionals, and I think I think that's I think just continuing to be excellent and part of that workforce is actually super important. The last way might be education. Is if you have this is true in the MD profession. I think also in nursing, we do a lot of education back to our colleagues and in servicing, and I think I would encourage folks to take some of what they're learning and experiencing here and maybe develop a relationship with an educational institution that allows them to also pass along some of these skills and promote them. And because we're going to need this in the workforce. And right now the education is severely lacking.
I have one more question, just to be the annoying guy at the end with the extra question. But I really believe that there's a lot of value in this notion of product market fit. And I know a lot of our nurses are entrepreneurial and they're thinking about ways that they can be disruptive or do something that's, kind of a new thing. It's really hard to sell somebody something that they don't know that they need. And I know Doctor On Demand probably was facing that to a large extent. Folks were resistant in many ways, I'm sure, because it felt uncomfortable to be on a phone at first, just like you didn't want to move off the BlackBerry.
Yeah.
But, what are some learnings there about really making sure that your offering is what they would ultimately want and need? Because I think what people get stuck in sometimes is a spiral of, I think it's a great idea, but it's really not sticking. And just because you're so passionate about your idea, you don't tend to pivot or, evolve or get that kind of feedback and then resolve the issues versus just trying to plow forward with something. So how do you know when to plow forward with your thing versus really keep pivoting and changing,
Wow, that's a good question. I think I agree with you that product market fit is super important. And to be able to be good at that, I think you have to listen for sure. So you kind of have to humble yourself. And I was probably pretty lucky that I made the transition about 8 years into my career. Went to digital health. So I was working I was the second doctor hired, seventh overall person working with engineers and just people I had never really interacted this closely with before. But I went in, I don't know why I thought about this, but I just knew okay, I'm going to come in here with all these things I think I know because I came from a health and I worked in the government health system and at Stanford. And so I felt like I had seen a few things. And so I knew about all of that, but I knew about, but that was a world that all the people I worked with, none of them had ever done anything in healthcare before, other than the one other doctor in the company. So, and that doctor was more of an executive. So it was kind of an interesting moment for me. So I took the attitude of, I'm going to unlearn as much as I can before doing this. And so I would just say, if you can grasp or, the concept or embrace the concept of unlearning what you already know to be true, because it doesn't mean those things aren't true, but they just might be true in a certain context. You have to unlearn as much as you can and be open I think you're going to find the right product market fit. And so there were all these ways we used to do things. And the question of, well, why do we do it that way? Well, because we'd always done them that way that's just not an acceptable answer. So, I think that's a really important piece. And so you have to be humble and recognize that even though, there was some dogma that was proven in your old job, don't assume that's good enough or that's how it should be, because likely because you're on a different platform, you're going to actually be engaging an entirely different type of healthcare consumer. You just have to recognize that and think about that. So think about your market, your audience, and be very specific, I think, about who you're talking, realize about who that is and who you're talking to and who you're targeting, so you can get it right. And again, I'm not a marketing expert, but I think that, but I would challenge you to think a little bit, maybe like I've learned a number of things about marketing is what I would say. And I would say, challenge yourself maybe to learn a little bit about that and pay attention to how products are positioned, on the television or even on the radio. And when you start thinking about like, why are they saying what they're saying, and asking yourself, who are they talking to? Like, who are they actually, like, they're not, because you're annoyed by them because they're actually not talking to you in half those commercials. They're talking to someone but they do know who they're talking to. And so I think if you think about who, you want to talk to engage your service, and then be real critical about your metrics that you're going to use about how much can you spend to acquire that customer. I think that's just applying some discipline to that is what I would advise, but also being willing to pivot, because most people don't, let's put it this way, most people don't get product market fit right out of the gate. Like it's a process, and you have to iterate. And if you don't iterate quickly, you're dead.
Yeah, and I'll just say there's a lot of parallel themes there for nurses wanting to transition to a remote role as well. Like you're going to have to kind of rework, the resume, rework, your presence and online, and be okay to do that. There's a very clear picture when you're applying to, bedside jobs or, hospital jobs. Your resume looks a certain way, you're going to be talking about,
Yep.
JCO and like that kind of stuff, right?
Yeah. They don't know what JCO is. Let me say, like, they have no idea what you're talking about.
Right. So being able to, like, your customer, right? Like what company are you trying to make your customer, right? For that interview, for that, and you're creating this, what is that product, right? If you will, what am I bringing to the table that I think is going to meet what they're looking for? So parallel, I think, themes there to consider for our audience.
And I think thinking about what's good for the company, like also it's like, it's like what's good for the patient and what's good for the end user. We have to think like that, but then you have to say, okay, now there's another vector to bring into that, and like it's like, and how does it benefit the company? And I think if you do, or your company, and that's totally okay to do that, because if you have your heart in the right place and the right values, and you're building something that's meant to change and transform and drive health forward, then you need to then you have a responsibility to make sure the thing survives, right? Like that's what you're fighting for, is make sure that survives and is sustainable. And then you can, you'll make compromises, but I think that's when the core values become very important. It's like you'll realize, well, I can compromise on these things, but I can't on these. And I think that's how you get to an outstanding, high quality service.
Great.
Amazing. Okay, well, thank you, Dr. Tong. Ian, since we're going by first names, that was a wonderful talk. Thanks for taking that toughie at the end there. Appreciate it. We will give everybody a second to migrate over to the next talk. I'll try not to kick people out of the entire webinar. I think I might have done that when I exited last time. So hopefully you can all migrate over to Olivia's talk. We'll kick things off in a couple minutes. Thanks, Ian, so much. Really appreciate it. Good to see you.
Thank you so much.
Bye.
Appreciate it.
Take care.